who don't know me, my name is Phelan Murphy. I'm one of the joint clinical directors for the STPN Paediatric Network. Thank you all for joining us today. So why are we doing this and what is the importance? Well, you clearly understand the importance of it because pain is fundamentally one of the biggest issues that we have for managing all our patients. Children's pain has been problematic and quite patchy. Laura and the team have been doing a huge amount of work on this, and this whole concept really comes from what Laura has found and all those visits that she's made. So there's been a number of visits that have been made to each centre. The surgical service, which is mostly Laura, has gone and seen every site, and also the STPN has been to every site on more than one occasion. And throughout all those visits, one of the key issues that's come back over and over again is the variation within the management of pain that occurs for children in all parts of the hospital and within their entire journey. And because of that coming through, Laura went and very bravely did a survey to assess the variations that occurred. And what we found was not just variations between tertiary and district general, between surgical and medical managed pain, but also between services themselves, within pain teams. They would have different views on what was going on and what could occur on different units. So with all that in mind, the team led by Laura have gone on and created this wonderful kind of pain guidance document, which we are launching today, but we're also circulating to many, many members of the STPN within the region. And it's also being discussed within the regional team and within London. So pain is very much not only the topic of this month, but will be the topic of the rest of this year. And all I can say is that the team has done a fantastic job. You know, they know how much I appreciate the work that they do, but I really want to stress to everybody here that they've done a fantastic job to pull this document together. Many times during this, I have gone, oh, why are we doing this? This is insane. This is way too much work, but the outcome is going to be great. And the fact that we're now engaging so many of you in this work is only going to make things better for you and most importantly for your patients. So I'm going to hand over to the team who've done a fantastic job. Thank you.
Thank you, Phelan. So yeah, we started off, as Phelan said, with a scoping exercise to look at paediatric pain management. And we used a questionnaire that went to all professionals involved in the acute care of children. And we looked at, when we were looking at the surgical pain, we looked at it in both elective and emergency care pathways. Really, the only types of pain we did exclude was chronic pain and palliative pain, but we very much did look at acute pain within oncology pathways. So our aim was to understand the quality of pain assessment and management across the network, and to understand where there were variations in care, but where there is standardization. And we really wanted to highlight the barriers and limitation to the provision of the highest quality care. So we got some interesting results. We had nearly 100 responses, and our findings, I hope you can see this, that first pie chart looks at pain service provision. And the yellow section there, so nearly half said that they had no pain service that covers children. And so this survey was answered by a real range of the multidisciplinary team, kind of an equal number of anaesthetists, nurses and surgeons and clinicians working in emergency medicine, and relative to the numbers that really exist. So yeah, nearly half were saying that there was no pain service. That blue slice of the pie, the 12%, had a dedicated paediatric pain service, and they were all coming from our tertiary and specialist centres. And then the red section, which is what we were hoping to see as a bigger section, was yes, there was a pain service provided by an adult or all-age pain team. And when we looked at the kind of out-of-hours provision, we found that the respondents said that in 3/4 of them said that there was no pain service provision out of hours. And whilst that might not be correct, there may be pain service provision by an on-call anaesthetist, and is unlikely to be correct. This is what our respondents believed and felt as they responded to this. When we looked at pain assessment, we asked individuals whether they thought pain assessment was done well within their setting. We saw a real variety of responses, 5 being yes, managed very well, 1 being managed poorly. So some positives to take from it, but a variety of responses. When we looked at NCA and PCA provision, we found that 40% of trusts were offering PCA only, and only a small percentage, 33%, were offering both PCAs and NCAs to their patients. A small number offering NCA only, and quite a large section that either didn't know or were offering neither. About half of our centres had access to training and education on PCAs or NCAs, and another half either didn't know or didn't have access. And when we looked at whether background infusion rates were offered on those analgesic pumps, only half of the respondents said yes, they could offer a background infusion rate to offer steady dosing. The rest didn't know or said that they couldn't offer those. And when we looked at how easily PCAs can be initiated in a ward patient needing escalation of pain, again, those responses from positively at number 5 down to negatively at number 1 did vary, although glad to see that 1 wasn't scored at all. And when we looked at some sentinel procedures, and we did this across different specialties, but just showing you here the abdominal pain questions and appendicectomy, we asked clinicians whether they were likely to administer or prescribe an opiate for a child presenting with abdominal pain. It was a really varied response, but the abdominal pain pathway from getting it right first time really advocates for decent analgesia to get on top of that pain. And we looked post-appendicectomy at doses of simple analgesia, and it was split into thirds very nicely, but only a third offering maximal post-op milligram per kilo doses, another third offering the standard milligram per kilo, and then a third offering age-banded doses, which we know can often be quite underdosed when children fall at the top end of those age bands. So just one last summary slide of our findings, just a couple of quotes from clinicians, and we saw real patterns of trust guidance not being appropriate for children, and there being no accommodation for children, kind of a reluctance to escalate to PCA and NCA, and not being done very often, and therefore confidence being quite low. And sickle cell crisis was one area that was of concern in some of our trusts, where ability to support pain in those patients was limited by the ability to provide PCAs. So what did we do with all that information? Well, we set about forming a recommendations document. And this was designed to respond to that identified variation. And we wanted to make some broad recommendations for what a group of experts would feel was the best practice pain management for the network, and to ensure there was clear escalation pathways for children that were suffering from pain, and include access to an all-age pain team. So we managed to pull that document together by creating a task and finish group, and we enjoyed excellent engagement in this. Massive thanks to all those people in purple, and there are probably people that aren't included on there that have been involved, and if you're one of those, let me know, because we can add you to the document still. So we had a real mix of anaesthetists, pain CNSs, surgeons, pharmacists, nurses, anyone involved in the management of pain. We started with our tertiary services and the specialist pain services, but quickly realised that to make sure this recommendations document was realistic and applicable, we needed representation from secondary care, and we found lots of pockets of expertise and knowledge in our seek to get help there as well. And we met regularly over the past 12 months. It's probably even longer than that now, and we used existing guidance, of which there is a lot, even for children's pain, both national and more locally. We used expert consensus, but it was the bringing together of all that in one concise document where we think we were able to achieve something unique. And we've developed a comprehensive practical document which has an executive summary and infographic and some other things that we've done to make the document as user-friendly as possible. We acknowledge it's quite large, so it has a interactive contents page, and big thanks to Joanna Renas, who's our project manager, who's made it as user-friendly as possible. We developed an infographic that you can see there on the screen with QR codes down the right-hand side and along the bottom that directs you to the relevant sections of the document. And much of the detail has been put in appendices so that the reader doesn't get bogged down in that and can refer to the relevant sections as they need them. Key messages have been highlighted, And we really promote this as a reference document, not to kind of be consumed in one go. And it's available on our website, which I'll show you now. So this is our web page. You can see a small blurb, and then the infographic is there, which is clickable on. And then the network recommendations are there under network recommendations and resources. The top one will take you to the whole document, but all the other relevant sections are beneath in hopefully a logical order. That little blue button there, share your feedback. Please do just let us know if there's things that you think we haven't worded properly or clearly, or areas you think have been excluded that would be useful for you and your teams as you support implementation of some of these recommendations. So yeah, really keen to hear your feedback. So the key messages really we wanted to achieve, and these are outlined quite clearly in the front of the document, we really want to achieve parity between the care that adults and children receive. We don't want them to be left behind in the quality of pain management that they get. We want to make sure children aren't being referred to tertiary care principally for the management of pain. There'll be many children that need to be transferred anyway, and pain is part of that reason, but not for the primary cause. The document helps us to select developmentally appropriate pain tools, and we really spent quite a lot of time making sure that they can be individualised and utilised for children with additional needs, communication barriers, and learning and behaviour needs. We want to ensure that all children get adequate and appropriate analgesia, and pain is escalated with the same urgency and attention as all other clinical needs. And we really want this to be a multidisciplinary, child-friendly, where we hear the child's voice, and family-inclusive approach to make sure that is applied. We use a multimodal analgesia approach, as per I'm sure you're all used to in your practice, but making sure that non-pharmacological interventions are encouraged as much as the pharmacological ones. We look at children in acute care having access to a trust pain team, and that's really kind of the crux of the document, making sure that children can access an all-age pain service where children's pain services aren't available. And we talk about how we can empower those all-age pain services later on in the slides. We recommend that trusts have a named lead for paediatric pain, and that's allocated in every trust, as well as some pain ambassador nurses as well. We look at clear escalation pathways for PCAs and NCAs, and making sure pain management is considered across the whole patient pathway. So for elective pathways from pre-assessment right through to discharge, but similarly in emergency cases too, or medical pain. We really want doses of analgesia to be optimized and adequate for all children, and so there's detail around that. And then just ensuring that robust monitoring and documentation and the governance around pain management, and a real kind of drive for audit and training and quality improvement in that space. So just to go through the contents in a little bit more detail, Carla's going to talk about paediatric pain assessment shortly, but just to introduce it slightly, the pain assessment tools are available within the document, and there is guidance on which ones to select, and we recommend that a range of tools are available within each environment. And we look at multi-dimensional assessment where pain is more challenging, and really that inclusivity for children with learning, behaviour and communication needs is covered. There's a full chapter written by our educator Becky, but endorsed by a learning disabilities and neurodiversity nurse specialist as well, making sure that we consider all aspects of their needs, of their care. Then the document goes on to look at analgesia algorithm, which is very familiar to you all. I'm sure it's based on the World Health Organization pain ladder. So we look at multi-analgesia strategy, both non-pharmacological, like I said earlier, and pharmacological. So the non-pharmacological interventions, including physical methods like positioning and using heat and touch, and parental involvement, and then psychological behavioural techniques such as relaxation or and breathing techniques and psychological preparation, and then the simple things we can do around environmental and sensory techniques like keeping lights dim and lots of other sensory noise reduced. And we look at the role of play, and Julie is going to talk to us, our pain CNS from MTW, about that shortly. Looking at the pharmacological side, there's lots of detail here around the analgesia. We include analgesia monographs within the document, which I'll show you on our next slide, and as though they are inclusive as possible, we reference out to formularies and other practical resources. There's some focus on adjunct medications and how to optimize analgesia post-operatively. So looking at milligram per kilogram dosing and post-operative dosing, as well as encouraging kind of the child and parent, empowering them to speak up when they feel they need more analgesia, avoiding trough effects, weight-based dosing, and continuing that at discharge as well. There's a large section on safety observation and monitoring, particularly in relation to the provision of PCAs and NCAs, and we look at the provision of those, which we cover later on. There's a section on prescribing of extremes of weight, so that we can care for those children appropriately as well and safely. And there's sections on blockade, peripheral, central, including intrathecal analgesia and wound infiltration as well. Wound infiltration anaesthetic. And then we look at step down of analgesia. These are the monographs. This is what they look like in the document. They're relatively detailed, and lots of work have gone into making these correct. But what we would say is Clinibi is a really great resource, and this holds the South East London paediatric formulary. This is really very helpful for more detailed information about those common drugs, and anyone with an NHS email address can access it. You need to then build a login, and you do have to log in every time, but if you download it on your phone, then that removes that step. So we really recommend that, because our monographs can't be inclusive of all the contraindications and cautions. So this is what it looks like when you go onto the website, and this is what you're looking for, the South East London Paediatric Formulary, and then you want to click into the clinical drug monographs, and then you get an A to Z of all the drugs, and that is what the paracetamol monograph looks like at the beginning of it. So really recommend that, as well as obviously your local formularies and the BNFC, which has also guided what's gone into our monographs. This is what the app looks like, and it's available on Apple and Android devices. So there's quite a large section in the document on the provision of PCAs and NCAs in children, and we really wanted to highlight that they should be accessible to all paediatric patients. Now, you may run a service where you don't think there is a need for PCAs and NCAs, and that may well be the case, but there are, say, an elective surgical hub, but most of our services are taking acute children in through their emergency department. So any of those trusts have got the possibility of needing to escalate those analgesic infusions, say, for example, post an appendicectomy or a child with sickle cell. So accessibility to those is really a high priority within the guidance, regardless of their age, weight or developmental level. So NCAs as well as PCAs is what we're advocating for, with no exclusions for just those things, developmental stage and weight. So we provide within the document some standardization and protocols, and we recommend that trusts implement those clear protocols, ideally adopting weight-banded standardized drug infusions, which have been recommended in more recent years by the RCPCH and the Neonatal and Paediatric Pharmacy Group. And that standardization ensures an ease of preparation, reduces the risk of error, and supports consistency in clinical practice, enhancing patient safety. As a network group, we recommended that trusts align with that, but we also recognise that it's perfectly acceptable for trust to use 1 milligram per kilo, kind of bespoke infusions as well. But we just wanted to highlight the kind of the most up-to-date practice. There's lots of details around infusion pump safety, so event logging and data sets and drug libraries, as well as the locking mechanism and the anti-siphon lines, and making sure pumps are up to date and serviced. And then it looks at the choice of agents, asking clinicians to consider the eligibility of patients, perhaps if they've had any renal or hepatic impairment, or have had any respiratory, history of significant respiratory illness in the past, the eligibility to morphine and whether other agents should be considered. And then looking at the prescription, and we were advocating for allowing background infusions to make sure that dosing is continuous and doesn't have kind of a trough effect. And then looking at the adjunct medicines available. And then there's a large section written by our critical care ODN around the safety, observation and monitoring of children on those infusions. So thinking about correct eligibility, families being briefed, and staff clinical competence, and making sure the prescriptions within those protocols, capping at 50 kilograms. This is what one of our standard protocols looks like on the left there. That's for morphine, NCA, and PCAs, and those standardized banded infusions. And this is an observation chart. Those are all included in the appendices. My last slide until I move on to our experts, but the recommendation document then goes on to look at pain service provision. And like I said, we're really advocating for all age pain teams where specialist paediatric pain teams can't exist to take responsibility and some accountability for looking after children within their remit where that's not happening already. And so collaborating with the experts available within the trust, which will probably include the paediatricians, the anaesthetists that regularly anaesthetise children, and the pharmacists that are looking after our paediatric services as kind of key stakeholders to kind of come together to discuss challenging pain scenarios so that we can get it right for children. And like I said earlier, we're really advocating for a lead for paediatric pain, somebody that has an interest, somebody that is prepared to, further their level of expertise in the area, and really advocate for a good service within their trust, as well as the pain champions and link nurses. And there is broader network support. From this, we hope to develop communities of practice and bring together, the expertise that we do have in our tertiary centres and support you with your decision making. And then the document goes on to look at elective surgery, so looking at that whole pathway for pain planning within pre-assessment right through to discharge and pain relief. And there's an excellent section on education and training, which highlights a lot of resources that are already in existence, and Becky's going to highlight some of those to us later on. There's a case study that just reflects some of the concepts within high quality pain management, and then there are speciality specific pain management sections to support you with certain patient groups, and you can see those listed there. There is a chronic pain section, just so that we're acknowledging that is different, and there are separate services that manage that, although they are few and far between. But the Evelina Children's Hospital has one, and there's details from them within that. And then there's the appendices section. So that's the gist of the document. That is what is in it. I'm only giving you a taste of the detail, obviously, but I'm really pleased to say that I have a group of experts here on the network on this call as well, and we've got a clinical nurse specialist from each of our tertiary centres, and one from Maidstone, Tunbridge, Wales, which does lots of trauma and orthopaedic work. And so they're going to give you a little taste of some of the sections that they've been involved in or that exist in the document. So first is Carla, and so over to you.
Thank you. So just wanted to quickly go over, I know it's like a big topic, but pain assessment is not a one tool fits all. It heavily depends on the age, which we've stipulated age ranges, which you'll see on the next slide, developmental age, which we already know. But what is important is a lot of the time cognition and communication ability gets forgotten about. And then you have, of course, clinical context. So it's very individualized. It's meant to be repeated regularly. Not just go in, find out that the child's in pain, you do something about it, and then you reassess. It should be treated with the same urgency as all of the other clinical observations, as per Pew's nationwide has said. It's a way of giving the child a voice, and because we're in pediatrics, the family as well. And of course, then it's multidimensional. It's pain is not just physical pain, it's the emotional part of it, the behavioral part of it, the memory of it, the functional part of it, and then what we see sometimes is just the physical part of it. So here we have just a quick look. So it's important to know that in the idea of multidimensional assessment and inclusivity, you can use more than one pain tool. So for example, you have pre-verbal and infants, you would normally think to use a behavioral observation for obvious reasons, they can't speak. So an example would be a FLAC, a face, legs, arms, one where you look at the actual parts and then you add up, and then a NIPS, which all this is explained in the project. Then you have young children, and this is anywhere between 3-year-olds and 5-year-olds. So this is where you can give them a voice. There's nothing wrong to say you can use a Wong-Baker Faces scale, but a 3-year-old may not have the cognition to pick a face that they feel. They might choose the face they like best, or they might choose a face that they don't like. And anyway, it might not be what you're asking, or it might be a face that they feel in like their mood, as opposed to what their pain is. It's asking a lot. So you can give them a voice and say, this is, the child says my pain's an 8. If you look at the Wong-Baker Faces, but it is very good practice then to add in the behavioral observation where you use the FLAC and you look at their behavior, and then you can use both of them. And in adults, I'm pretty sure using 2 pain tools is quite alien, but in children, it's very, very common. And then in the older children, we have a different problem. They do self-report a bit more, but then they have, as I mentioned before, previous issues where they don't want to be in hospital. They might be in hospital a lot of the times, so they might not tell you. They might tell you what you want to hear, so you can go away. So then, in that respect, again, give the child the voice, give the teenager, the young person the voice, but also do behavioral observation. And this is where the parent also comes in, because they are with them usually. The whole time, from the beginning to where we are at that point. So then the child's voice, yes, but also it also gives a chance for the parent's voice to come in as well. And then you have children with additional needs. So this, with the RFLAC, you can do a very individualized behavioral assessment. So you can really sit down with the parent at the beginning, the first time you meet them, or in pre-assessment, or before surgery, and go through, like, what are their pain behaviors normally, and what is the difference between, what does their cries sound like when they're in pain versus when they're hungry, and this kind of assessment, you just sitting down having a conversation with the parent of a additional needs child. And if it's got a neurodivergent child, again, using behavioral and other things that will be talked on later. But again, one assessment tool is not enough in pediatrics. From the age of 0 all the way to the teens, you should be able to be using behavioral and self-report. Yeah, and so consistency in assessment improves the escalation and continuity of that care. So once you have an assessment of the child, you do something about it. you have an action, you either give a pharmacological action or a non-pharmacological action, and then you go back and reassess within an hour to see whether that action has actually worked. And what I'm trying to get across is that these reassessments are support to the pain tools. They don't replace clinical judgment. So that's the main tool, main idea is clinical judgment always matters alongside the pain scores. Thank you for listening.
Thank you so much. That was a great introduction. There's a wealth more knowledge within the recommendations document. Now, we've deliberately put non-pharmacological interventions ahead of the pharmacological, just so we don't forget them. And Julie Doherty, who is a paediatric orthopaedic pain clinical nurse specialist from Maidstone, Tunbridge, Wales, is going to just introduce some of the details that we have within the document. Thanks, Julie.
Hi, thanks for having me. So I'm going to chat to you about non-pharmacological interventions. Non-pharmacological interventions are equally as important as the pharmacological ones. It's really important to remember they are everyone's responsibility, from the parents of the child through to the medical team. That's nurses, healthcare, play specialists, receptionists, anaesthetists, surgeons, everybody. We're all responsible. Really important to remember that stress and anxiety plays a huge role in pain perception, and a frightened, nervous child is likely to have their pain experience exacerbated. Fear prior to procedures beginning can heighten child's perception of pain, and negative, distorted memories of painful experiences have been linked to greater distress during subsequent procedures. So it's really important that we get it right first time, that when children come to see us for their first ever blood test or their first immunisations, for example, we don't send them away frightened of ever stepping back into our departments. The level of distress that children can experience during those painful experiences can really distort how their memories are formed. I don't know how many of you have memories of going to the dentist as a child, and just the smell of the dentist, or the bright lights in the dentist, or the sounds of the drills can have, make you feel frightened before you've even gone into your appointment. I know I don't like them. And a really good example of that is the plaster saw. As a teenager, I had lots of plasters removed, and even now as a nurse, when I often support children through this, I still get that funny feeling in my tummy when I hear the sound of the plaster saw. So I'm really, really acutely aware that these sounds, smells, lighting, all these things affect how children remember pain and how it can affect their pain experience. So with our non-pharmacological interventions, we need to be really mindful of how old our children are, and making sure that what we're doing is developmentally appropriate for them. So all our education that we've got lots of education for pre-op, for example, in different age groups, so that you can show a tiny, a small child, they may relate to Peppa Pig or Hey Dougie, but you wouldn't want to show that to a teenager because they just look at you as if you were stupid. So it's about getting that right, the age and the developmental appropriate things, with all our preparation for surgery or for blood tests, etc., making sure we use those things. It needs to be multidisciplinary, as I've already said, and kept child-friendly and family inclusive. It's really important to involve the children's parents, siblings, whoever is close to them, and coming with them on their for their appointments, because they're the people that mean the most to them. They're the people that know them the best. We often see children in clinics that have got a really good bond with a sibling who are actually perhaps really supportive for them. So it's really important to involve them if they're present in the care. So therapeutic play is a really important use for preparing children for procedures. We've got health play specialists. We should be getting them involved in preparing children for things that they're having done. And they're also great in an emergency situation. If you're in an accident emergency, for example, you've got a child with a broken arm and they need to have a plaster applied. Play specialists can do immediate distraction things before the procedure, as well as using our pharmacological things, of course. So what sort of techniques do we use? So there's the physical techniques, the things that we all probably do without realizing it, you know, the holding, the comforting, the touching, the gentle stroke on a child's forehead when they're frightened, touch, massage, the use of ice for painful limbs, swollen ankles, you name it, ice can be brilliant. The use of cold spray prior taking blood, use of splinting for painful limbs, using positioning, all of these things are useful techniques. So then when we're thinking about the psychological and behavioural techniques, we're looking at distraction, play, using toys, books, storytelling, iPads, VR headsets, bubbles, counting games, you name it. There is loads of things out there to help prepare and educate children prior to procedures and painful things. The use of relaxation and breathing techniques. So we're thinking of things like guided imagery, hypnosis, even CBT. All these things are really useful in preparing our children for painful procedures. So we were talking about sensory and environmental techniques. So thinking about, for example, going into the anaesthetic room, can we reduce the number of people that are in there? You know, is it going to be really daunting for the child to see a room full of people and suddenly they feel really, really vulnerable? Can we turn the lighting down? Is there a way of making the room quieter, or could we play some gentle music or some music that they're, you know, their favourite tunes, what works for them, and making it child relevant to that child. So an example of the anaesthetic room with our children at Tunbridge Wells, we've got some fabulous bubble machines. They're really good for calming the little ones. But I had an older child the other day coming back from theatre telling me how the anaesthetist had given him a water squirter, which turned out to be a syringe full of water. And he was squirting the bubbles with the water squirter. And that he was so excited about it, couldn't wait to go home and squirt his brother. And that was really lovely, that distraction technique that was used in the anaesthetic room in a place that could be frightening and could have given, you know, exacerbated his memories of having that procedure. All he could think about was how much fun he had squirting the bubbles with the syringe of water. So these things are all useful. There's loads on the guideline to have a look at, and any questions at the end, I'd be happy to help answer.
Thank you, Julie. That was wonderful. So next we're going to just have a quick focus on pharmacological interventions. And we've got Roberta Woodford with us, who is a pain clinical nurse specialist from the Evelina Children's Hospital. So over to you, Roberta.
Thank you. So obviously when we're talking about pharmacological interventions, this is a huge section. And the idea of this is to really kind of provide you guys with the tools to utilize as many different pharmacological methods as you can, obviously in addition to your non-pharmacological interventions. There's a landing page on the document which has some of your key takeaways. So some of those things are considering the type of pain that your patient might be experiencing. So is it acute post-operative pain? Is it procedural pain? Is it a combination of these things? And then do you need to combine different pharmacological approaches? Are there things that you can kind of add in on top? Are there things that you can add in that might reduce the need for things like opioids that do obviously naturally come with certain side effects? Thinking about your escalation process, working your way kind of up using the algorithm, which we've got on the next page, which we'll be showing you, looking at how you can optimize the drugs that you're using, or even optimize the dosage. Are there things that you can do with the particular drug that you're using before you think about escalating to a different drug? Equally, have you used a particular family of drugs, such as opioids, where they're naive to an opioid, so they're naive to morphine, they experience lots of side effects? Is there kind of a sideways switch that you can make that might really improve your patient's outcome? Looking at weight-based dosing, there's lots of information in here about whether you need to consider the need for ideal body weight or adjusted body weight with some of these drugs, particularly important when you're thinking about some of your stronger drugs, such as your neuropathic agents or your opioids. Also drawing your attention to obviously some of the dosage that we've got in here, but I think, as Laura said earlier, there's so much to put in that you cannot naturally cover everything. So obviously it's signposting you to the South East London formulary and the BNFC, and I would encourage you guys to look at both, as sometimes there are different indications in both. Consider your formulation and your route availability of all of these different drugs. Are there certain things that you haven't explored that you might be able to? So for example, for your nil by mouth patients, there may be certain IV drugs that you haven't considered before. And obviously what's really important when you're looking at your pharmacological interventions is thinking about your patient's medication and pain history. So have they ever had a painful experience before? Did they receive certain drugs for that painful experience? What worked for them? What didn't? Do they have a history of kind of chronic pain in the background? And actually, do you need to consider a different approach when it comes to their acute pain? And that's what they're coming in for. We're looking at the algorithm. So we're looking at our multimodal analgesia. So obviously, as well as combining your non-pharmacological and your pharmacological approaches, you're looking at the way that you combine all of these different drugs. So it's based on the World Health Organization analgesic ladder and kind of branched out from that. So you're looking at your more simple analgesics towards the top of the screen, which is your paracetamol, your non-steroidal anti-inflammatory drugs. And then kind of as you're moving down, you're looking at more severe pain, what you might need to consider adding in for your patients or switching to. So you've got options of weak opioids such as dihydrocodeine, or moving to stronger opioids. Thinking about your adjuvants, do you need to add something in such as clonidine or diazepam that might enhance the effect of your analgesia and help it to work more effectively for your patient? And again, is your patient having a procedure on top? Do you need to add something in that's short acting as well as your long acting in the background? You can think about lots and lots of different ways that you can approach things. Within that, we've got different monographs, which I'll show you one of them here. This is your ibuprofen monograph. Obviously, it seems like quite a simple one, but I thought it was a nice one to draw your attention to because it's got your oral and rectal options, and it also has intravenous ibuprofen, which is a relatively new thing that some hospitals are using. We're using it ourselves at Evelina. This is where it's really important to utilise both your BNFC and your South East London formulary, because in the BNFC, it's unlicensed in 6 years, so there's no information there. However, in the South East London formulary, we have usage on over 6 months. So that can be particularly useful for your patients who are nil by mouth, who can be given IV ibuprofen with obviously gastric PPI cover, as long as they don't have any other sort of contraindications. There may be other things that you can add in like this that you may not have considered before that prevents you from moving to a slightly stronger analgesic that may come with associated side effects. One of the last things I'm going to go over is all of the information that it's got in there when it comes to NCAs and PCAs and some of our local anaesthetic infusions, where there's lots and lots of information on your safety, observation and monitoring. So if you guys are wanting to utilise these things that you've not done before, or say if you've utilised a PCA with just boluses and people have been reluctant to use a background, this may provide you with the tools to do that safely, and provide people with some reassurance to use some of these drugs a little bit more widely in your hospitals. As I said, I'm just kind of scratching the surface, so I'd really encourage you guys to go and have a look at the document yourself. There's so much information to be found in there, and it will really, really help you guys out, hopefully.
Thank you so much, Roberta, and the rest of your team for all your expertise that you've ploughed into this. Really appreciate it. Lastly, but definitely not least, is our final paediatric pain clinical nurse specialist, Josephine Rhodes, who comes from the paediatric service at St George's University Hospital Trust. And she's looking at managing acute pain pre and post-operatively for surgical patients.
Hi, thank you, Laura. Good afternoon. So I'm going to use the example of a 9-year-old with appendicitis. I think most of you will be very familiar with that sort of presentation. I'm going to look at how you can manage them preoperatively and then postoperatively. I think pre-op analgesia sometimes gets a little bit forgotten. If you're at a very busy trust like myself, unfortunately, sometimes children have to wait. You know, if they're stable, they might not be able to be operated on straight away. So if you imagine we've got this 9-year-old diagnosed with appendicitis, she's in the bed, lying quite still. She's happily more happy if she's looking at her iPad. So that's some non-pharmacological distraction coming in there. Some nausea, which needs monitoring. She might end up needing some IV antiemetics, but currently she's eating a little bit. So the idea with the document is that it's flexible. There isn't one way to look after post-op pain or pre-op pain. So she is giving some nice pain scores. Her pain score at rest is a 5 out of 10, and then up to an 8 when she's moving, which is very typical with appendicitis pain. Now, if we imagine she's going to be listed for surgery first thing in the morning and you've got her on the evening, what can you do for her? So currently, I would say she can have oral paracetamol. She can have some ibuprofen if she's eating. So try and do those regularly overnight. And then she might need something like Oromorph. So don't hesitate to have that PRN. And then the nurses aren't running around, trying to get a prescription if her pain escalates. In a second, on the next slide, there's a reference to the Getting It Right First Time guidelines, which Laura's mentioned already. They're really worth a look. That talks about the evidence behind, well-controlled pre-op pain. I think as pain nurses, we really rely on that relationship with the patient, with the parents. We often follow patients through for a number of days. So if we can get on top of pain from the beginning, even before surgery, it really helps us to then get the trust of the child and the family. If she then goes for her surgery, she might well need a PCA, particularly if it's a nasty appendix or she's got pus or something like that. So we love multimodal analgesia approach as in the pain world. So keep going with your paracetamol, your ibuprofen. You might need to do IV paracetamol, and something like PR diclofenac is fantastic for post-op appendix. I'm not going to talk too much about PCA management. We've got plenty of guidance in the document on that, but as that PCA naturally weans, as the girl uses it less, you can think about things like dihydrocodeine. They're a nice bridging drug when you're coming off a PCA. So you can, as well as the analgesia you're going to use, there's just some general guidelines here which are quite good advice for any type of patient that you have post-op. I just want to point out, really important, we do quite complex surgery at St George's. I think other trusts will be the same. If the pain is escalating more than you're expecting, let's say day 2 or day 3 post-op, definitely have the surgeons come and reassess, because there could be some post-op complication and they can be quite serious. So listen to what the nurses are saying. If they're not following that trajectory of the pain gradually improving, then it needs a careful reassessment. As I've said, we need the parents on board, we need the carers on board, and we can empower them. I like to explain, what breakthrough analgesia is prescribed so that they can ask for it as needed. So they can be like your allies. And then some parents have questions about, opioids, potentially masking, a complication. So it's a lot of reassurance when you're talking parents through what analgesia they can have. I think explaining that the dose is carefully titrated to their child's weight is always helpful. And then finally, just wanted to point out those references. The second one there is Getting It Right First Time. That is, it's very simple, a nice guideline. It's quite up to date, but it particularly stresses that, the better you control the pain pre-op, generally the better it is post-op. And the Melbourne Hospital has a really nice app with lots of nice guidelines. Thank you.
Thanks very much, Josephine. That was really, really excellent view on that part of the document. We are running short of time, but this is a really important section. So over to you, Becky, our clinical lead for education.
Then I just want to quickly whiz through this, just to say that there are lots of education resources out there which are all listed in the guidelines.